Hi, everyone. Welcome and grateful that you've registered and joined us here this evening. I know we're all across the nation here, and of course, it's only 5 o'clock for me in Mountain Standard, so there are folks joining at 7 Eastern, and of course, 4 if you're in clinic still on the Pacific Coast. And I'm Viet. I'm a former or past president, I guess, of the Academy of PAs in Cardiology. I'm currently at Intermountain Health, where I am an associate professor of research and a preventive cardiology PA. I serve on multiple committees with the American College of Cardiology, of course, kind of ex officio, maybe, with the executive board of the APAC, and then just all around lipid kind of person. So um, I don't I don't know, Laura, if you want me to say anything more or
Yeah, well, we're so thrilled to have everybody here to learn from one of the best. Viet has been in the lipid space for a long time, and he welcomes everyone who wants to learn more about triglycerides, of course, myself included. And so, the Academy of PAs in Cardiology is a constituent organization of the AAPA, but we welcome anyone who wants to learn more about triglycerides and how to take better care of our patients. And so, we're excited you found us here. Know that at cardiologypa.org, there's many more opportunities to get involved. And with that, I'll pass it back to you, Viet. Thank you so much for speaking about the latest hot off the presses 2026 dyslipidemia guidelines and really paying attention to this residual risk factor of elevated triglycerides.
thank you. Yeah, triglycerides are back. I mean, this is great. They kind of fell out of the 2018 guidelines and then resurfaced in their own expert consensus decision pathway, which you might recognize in 2021. So they're now back in one document with the other lipids. And so without further ado, we'll kind of move forward here. It's always important to recognize that, like, what we're up against. I don't think anyone here is, that it's a mystery. There's a lot of heart disease going on. And so, if you just think of the length of this talk, um, if we think of a stroke occurring every 3 minutes and 14 seconds, that's, boy, that's about 20 strokes that'll occur. Hopefully, I didn't cause them, but they're occurring during the time of this talk. And then you look at just cardiovascular disease events, which will include MI, peripheral arterial disease, all the other things that are atherosclerotic. That's one every 34 seconds. Folks, that's 120 people who will have an event during the time of this talk. So, what's happening here? Well, diabetes, prediabetes, affects over half of US adult population. This is metabolic disease. And why do I bring this up? Is because it's a metabolic driver of why we see elevated triglycerides in many of our patients. And if you have a high triglyceride and low HDL, probably should check an A1C, or at minimum fasting insulin and glucose and get a HOMA IR calculation. But this is staggering. Only 23% of US adults with diabetes achieve recommended control of their blood sugar, blood pressure, and cholesterol. We need to do better. And so let's talk about how to do that. These are missed opportunities. So why triglycerides? What's the issue? What's the problem? We're so uber focused on LDL cholesterol, the new sexy, exciting LP-A. It's not new, by the way, but that also gets some airtime here in the 2026 guidelines, universal screening. But where are we at? And perhaps I'll turn on a laser pointer here. And you can see on this very first slide that on the left-hand side, this is predicted cardiovascular risk, 0, 5, 10, 15%. And then based on the average baseline of triglycerides. And you know what? We say 150, but look at what happens at 100. It's a pretty steep climb through 150 to 200. And it actually slightly levels off from there on up from the cardiovascular perspective. So we're a little bit late. I kind of think of this like blood pressure, where we were waiting till 140 over 90, and finally the guidelines bring us back to 130 over 80. Well, just imagine at some point, we probably shouldn't be using 150, but drive this down to 100 in terms of reducing cardiovascular events. But look at this side over here. So this is the Miracle clinical trials or Miracle clinical trial. And this is from 0 to 16 weeks of follow-up. It's such a short period of time, but the risk of events, 5, 10, 15%, you have this just massive increase from a triglyceride less than 135, which by the way is not zero events, but then you go to 195 and it's a 50% increase in event rates. So we have to do better. Shouldn't be waiting till 2, 3, 4, 500 to pay attention to the triglycerides. Let's do it a little bit sooner. So the 2023 guidelines came out, of course, right after you can count years as well as I can. The 2021 expert consensus decision pathway, and then 2023, this chronic coronary disease guidelines gave us a little bit of help in understanding triglyceride management, but in the sense of like what not to do. So if you understand the classes of recommendation, one is like, yeah, please, this is like has great evidence or at least expert consensus on it. You get to 2A and it's like, yeah, risk is or benefit is better than risk. 2B is like, it's getting kind of equal. 3 is where we get upside down, where harm or benefit is just not there. And so in patients with chronic coronary disease receiving statin therapy already, don't adding niacin, fenofibrate, or dietary supplements, not helpful. Don't do it. And we saw that again in 2026 pretty firmly. Do not use off-the-shelf supplements in this space for lipid management and triglycerides. So then we look at the American Diabetic Association, and this is a living document. They're so good at updating live year to year. So here's 2026. In individuals receiving statin therapy, addition of fibrate, niacin, dietary supplements containing omega-3s, not recommended. This is a conversation I have plenty of time in clinic. And while we're treating biomarkers, we're not actually treating events or reducing outcomes. And certainly the off-the-shelf omega-3s can, in fact, increase LDL cholesterol, doing the opposite of what patients and some of us think when we're adding these dietary supplements. We get to 2026 now. Yay, March 13th, Friday the 13th. You're welcome. So here we go. And it's not that scary. In fact, it was quite a bit of great news for all of us in the lipid space. But I'm going to, jump past the lipids because it's not an LDL. I shouldn't say jump past lipids. I'm going to jump past the LDL cholesterol, ApoB, Lp(a), because triglycerides has its own section here. And this is what we're here for, right? Again, you should be somewhat familiar with this because this is what was seen in the expert consensus decision pathway from 2021. Here they break it out into 4 groups. Those with atherosclerotic disease and hypertriglyceridemia, so greater than 150 fasting all the way up to 500. Diabetes, age greater than 40, without atherosclerotic vascular disease or known, and still with hypertriglyceridemia. And then those without either of those, ASCVD or diabetes, but still have a fasting triglyceride that's elevated. And then finally, reserved, because everything's been 150 to 499, here is severe hypertriglyceridemia, which is now 500 and greater, and especially when you get to 1,000 and greater. What you need to remember is there's the cardiovascular component, which I showed you, it starts to increase at 100. And then there's the pancreatitis side of the fence, which then, you're saying, is there pancreatitis risk or there's cardiovascular risk, or is there both going on in the same patient? So of course, we evaluate, manage for secondary causes, meds, other disease states, et cetera, can cause this. And then, optimize diet and lifestyle. But if after all of that, they have persistent fasting hypertriglyceridemia, then we're thinking of other things. So let's move on to it. Okay, so here are some secondary causes of hypertriglyceridemia. I'm going to read through these. You have them in the 2026 guidelines. It's nice because they're in tables here. But as you look through these, they should make sense. People with CKD, lipodystrophy, uncontrolled hypothyroidism. That's why I get a TSH. Annually or even with a new consult, it's what I'm getting. Certain disease states here, diabetes, and then diet lifestyle. So that's kind of what then translates to what is optimizing lifestyle? Well, abstaining or reducing alcohol use, reducing diets saturated in fats, sugar, high glycemic, and of course, exercising more. As I move forward here, then these are the conditions and medications that contribute to hypertriglyceridemia. So hopefully you're not using propofol on a regular basis, and unless you just spend your life anesthetized. But the beta adrenergic blocking agents, thiazides, loop diuretics, now it's not massive increases, but it could be one of those things. And I would argue you have to look at this as risk stratification. Are we okay with slightly elevated triglycerides if we're managing another disease? And you have to think about that. Okay. And then, of course, the endocrine types of conditions here. And then as we move forward in time, these are other drugs used in these different disease states that can increase triglycerides. So I do a pretty good history, pretty expansive history in order to identify. But look, when people are referred to my clinic, they're in the 3,000 to 4,000, and I've seen as high as 12,000. This is kind of creamy tomato soup looking stuff. And I know, sorry, I didn't mean to ruin your dinner, but it's probably not just something like this, although it can add to elevated triglycerides. These drugs and disease states generally are not like the one thing. Maybe they're additive in terms of increasing the triglycerides. Some more disorders of metabolism, of course, overweight, obesity, metabolic syndrome. These are the things, right, that we have to manage. And so I would ask that you not target necessarily the triglyceride, but the disease state. And often that's in my clinic when we manage severe hypertriglyceridemia. If you manage the metabolic dysfunction, look at the drug states, et cetera, that are on board, then generally speaking, you can reduce triglycerides by quite a bit. Okay, so moving forward. Now, when to consider icosapentaenoic acid. So that's the purified form of icosapent ethyl. Icosapent ethyl is the purified form of icosapentaenoic acid. So that's why the IPE EPA here, and not to scare you with an algorithm. So we'll just kind of walk through it. This is for people who have atherosclerotic cardiovascular disease, hypertriglyceridemia, not severe, right? So 150 to 499. And then you've identified, managed all those secondary causes that we've talked about, optimizing lifestyle, physical activity, alcohol, weight management. You've initiated the things. And then you've optimized LDL cholesterol levels, because with ASCVD, they're often on a statin, you're adding ezetimibe, all of which impact triglycerides to a certain extent, as well as LDL cholesterol. But they're not asking you to optimize all the way down to less than 70, less than 55, but rather once you've reached less than 100 and still there's a persistent fasting triglyceride that's greater than 150 to 499, that's when we think of icosapent ethyl or icosapentaenoic acid. And again, avoiding class 3 dietary off-the-shelf omega-3s. Okay, so it's important to recognize those two things are true. Omega-3 is being recommended as class 2B, but actually it's prescription grade, not off-the-shelf dietary. So think about those. And then down here is really kind of in those really neat tables that you can read a little bit further into it. So that's the atherosclerotic cardiovascular disease. Now, when we look at diabetes without atherosclerosis, when do we consider IPE or EPA? These are individuals that are in that 40 to 75 years of age range, no atherosclerosis, but a triglyceride level at least above 150 and then under 500. You've already started moderate intensity statin, and the goal is less than 100, non-HDL less than 130. Maybe you've done that, but you've done a prevent score. So you don't necessarily need to do a prevent score in diabetes, but I think it's important because it offers a chance to intensify therapy in people if needed. And so if that score is 10 or greater, that's high risk, then, or multiple risk factors, you have CKD, maybe MASH, MASLD, et cetera, then you would translate that to higher intensity statin, at least a greater than 50% reduction of LDL from baseline. And now you're targeting those less than 70, less than 100 for non-HDL and LDL cholesterol. But if after all of that, and you've targeted these LDL cholesterol levels to the right levels, and they have persistent fasting triglyceride, 150 to 500. In this case, they went to 500, so it's a little off from 499, but that's when you would use icosapent, icosapentaenoic acid, or IPE, icosapent ethyl. Okay, so why are we even thinking this, and what should we be considering after all the LDL cholesterol stuff, right? Because despite all of our efforts from 4S, which is now 40 years old, through CARE, WASCOPS, this is pravastatin, this is simvastatin, lipid, AFCAPS, HPS, where we're moving into the atorvastatin side of the fence. It doesn't matter. Rosuvastatin with Jupiter. Look at this great reduction in relative risk, but the truth is that even on statin, these populations were having events, just less events. Whether it was 30% less or 50% less, they still had events. So we have to do more than just LDL cholesterol. And that's why it makes sense then to look at other risk factors like ApoB, like Lp(a), HSCRP, in this case, triglycerides, because that residual risk shouldn't just stand by itself by lipid lowering. Okay. So this is a nice, slide, Kaplan-Meier, that looks at percent events. So 10, 20, 30%. That's a lot of events, by the way. And then over years, 3, 5, 7 years. These are the standard of care, quote unquote, placebo groups that still received statin and had LDL cholesterol levels that were arguably fairly well managed based on contemporary management of these patients. So Fourier, the PCSK9 evolocumab, now known as Repatha, at 3 years, the event rate is 14.6%. Let me just level set. Remember, when we talk about the prevent risk score, we think of high risk as 10% in 10 years. So 3, 6, 9 times this by 3, and this is a near 40% event rate by 10 years. These are risky patients. 28% by 5 years, double that, right? 56% event rate in 10 years. These are high-risk patients that were already on statins, and these are standard of care or placebo groups. I really think that we are missing the boat if we're just looking at LDL cholesterol. And sure, each time we've done this, and the lower you get that LDL cholesterol, the less events, but we still are missing components, and there's still residual risk. So here's a case that I think is helpful to discuss and to bring us back to the fold here of like, what are we going to do tomorrow if we see patients? Or, if this is a weekend webinar, Monday, what are we going to do with Sally, who's 56 years old, and she's had an MI a year ago, hypertension, she's had hyperlipidemia as a diagnosis for 11 years, drinks 3 to 4 drinks a day. I think Sally has some stress, maybe. I don't know. I don't drink, so I'm not sure. But 3 to 4 drinks seems a little bit much. But her current medications: rosuvastatin 40 milligrams, clopidogrel 75, ramipril 10, metoprolol succinate 100, and estradiol 1 milligram. So, she's on some things here. Blood pressure looks great, 122/72, heart rate 76, BMI, she's, just under that overweight range. And here are her labs: total cholesterol 160, LDL cholesterol 75. Arguably, with an MI just a year ago, we could look at that and say, yeah, there's something we could do. But this triglyceride of 175, HDL 49, fasting glucose 78, A1C 5.2. So let's ask ourselves, let's do a hypothetical. What risk factors for hypertriglyceridemia should we address in this patient? Her weight probably isn't the issue here. She's not, at least by these measurements, doesn't have metabolic syndrome per se. and does not have any, insulin resistance that seems to be going on. There's no other medications here. Maybe estradiol could be bumping up the triglycerides. We've already said that once you cross 100, your risk starts to go up. Here it's 150. And if we were to think about the 2026 guidelines, this is a person who's on statin. LDL is less than 100. Remember, I know her goal is lower. I'm a proponent for less than 55 in her. But here, if you add additional LDL cholesterol, you're probably not going to reduce that triglyceride by much. Even ezetimibe, which will be like a 20% extra, reduction in LDL cholesterol, will get her just about at 60, but still the triglycerides would be sitting there. So this is a patient that perhaps based on the guidelines would be a 2B to initiate Icosapent Ethyl or EPA. So the REDUCE-IT study, where did we get this information? It was curious to me that in 2018, as I'm listening to them present the 2018 lipid guidelines, the very next talk in the late breaker is Dr. Deepak Bhatt, who famously says, already we've just presented the lipid guidelines and they are out of date because the REDUCE-IT trial, okay? Just so you know, what is Icosapent Ethyl? How's it manufactured? Anything that's off the shelf, this is basically how it starts, right? Crude fish oil. Yeah, I mean, right here is where it gets sent to a fish oil capsule. You can imagine if it's sitting out on a shelf, temperature all over the place, it's clear bottle, and sunlight, it becomes rancid. And this is why LDL cholesterol can increase and inflammation can increase if you're eating it's food, rancid fish oil capsule. But as we go through ethyl esterification, this is where that Icosapent Ethyl comes in. You do that first purification, here it is, and then intermediate, and then final. And really you get about 96% purity Icosapent Ethyl or EPA without all the rest of the stuff going on, and certainly without DHA there. Okay. And yeah, I mean, this is basically what it looks like. That's why those capsules are clear. So REDUCE-IT, what was it? Well, this is a population of 8,000 patients, men and women, who are already on statin therapy. So pay attention here. The way we design clinical trials is how the FDA indication occurs. That's why the current indication for Vascepa or Icosapent Ethyl, because there's a generic brand, is that you have ASCVD, you're on a statin, you're doing lifestyle things, and your LDL cholesterol is managed where it should be with a triglyceride greater than 150. And that's really what happened here. So as you look, LDL cholesterol is right in this level. Baseline was 75, the median, and then triglycerides were 135 to 499, although originally the enrollment was 200 at screening. Once people went through, on the other end, their triglycerides were just slightly lower, okay? Established cardiovascular disease, or this is the other indication, diabetic. So they have diabetes, over 50 years of age, and one or more risk factors. So you could just have diabetes with one or more risk factors of hypertension, CKD, and triglycerides greater than 150. But these were randomized, of course, placebo versus being on Icosapent Ethyl. And then the primary endpoints that we're all interested in is composite MACE, cardiovascular death, non-fatal MI, stroke, coronary revasc, hospitalization for unstable angina. Now, it's always important to recognize that secondary endpoints, we do these, but you have to call your shot ahead of time. That's why these secondary or post hoc analyses are a little tougher. It's a little bit easier to swallow, if you will, when the primary endpoint is statistically significant and at a high level. Then these post hoc analyses can make a little bit more sense. But in this case, they called their shot and said, well, not just the composite, all of these combined, if we met the endpoint, but singly, did these also meet endpoints afterwards? Okay, and this was a composite as well. So there's a key secondary, and then they broke it down later. Here are the baseline characteristics. This is Sally, really, 64 years of age. Here we have to do better. 30% were women. We need to increase that. But it's important to know that this trial enrolled about 2/3 of the patients that had events already, and then about 1/3 of them were quote unquote high risk primary prevention. So diabetic without any cardiovascular disease, but 2 or more risk factors. You can kind of see at entry how many, nearly 2/3 had a triglyceride level of over 200, but about 1 in 10 fell under the 150 mark here. Okay. And pretty good portion were on moderate or high intensity statin. And then all the other optimized risk factors there. And I mean, it's been since 2018. So hopefully I'm not doing any spoiler alerts, but this is what you're here for. This is great. I mean, both are on statins. And here with Icosapent Ethyl, we further reduced by 25% events. Now, I'm not going to blow sunshine because, again, residual risk tells us that even after we've done the things, we've managed the LDL cholesterol and we add Icosapent Ethyl, yeah, there's still residual risk. It tells you how risky these patients are in terms of having their next event. But anything we can do to reduce that risk, the better for it. So 25%. And I just love this. You need to recognize what number needed to treat means. So yes, 21 people, all of them have to be on Icosapent Ethyl, and in this case for 5 years to reduce 1 event. Okay. When we think of statin treatment in primary prevention high risk, it's about 80 people that you need to treat, all 80 on statins to reduce 1 event. So here it's 21 that you treat in order to reduce 1 event. So it's remarkable, actually, how well this works. So then the key secondary endpoint here, again, about 26% relative risk reduction, number needed to treat 28. You can look at the p-value yourself here, but I always giggle when I think of Dr. Bott, just 0.00000, and the audience is like, okay, we get it, statistically significant. Okay, so for the primary, this is the hierarchical testing. So once you meet your primary endpoint, now you can do hierarchical testing of everything else afterwards. And in this case, they just went until there was no statistical significance. And fortunately, they started with a primary composite, key secondary composite, cardiovascular death. By the way, of all the lipid therapies that we have out there, this is the only one that has shown impact on cardiovascular death. In some cases, we've seen the opposite. Even though the primary endpoint was met, the singular cardiovascular death went the wrong way. Here, it all went the right way. Fatal, non-fatal MI, urgent, emergent revasc, cardiovascular death, etc. As we go through this until total mortality. I can't stop you from, accidentally getting hit by a bus. But boy, it looks like Icosapent Ethyl is better on total mortality as well, not just cardiovascular death. So I think these are the things to think about and look at, but you can see the relative risk reduction. All of those were statistically significant until total mortality. So do you only have 1 event though? No. Case in point are these studies enrolled people who have had an event. 70%, in fact, in this study had already had an event. And what we were trying to do is at index, what was the first event, but then subsequent and total cardiovascular events that occurred in the 5 years of this trial. Placebo, it just kept stacking up. The first event, second, third, fourth. When we look at Icosapent Ethyl, yes, even if they had a first event, fewer of them had a second, fewer still had a third, fewer still for the fourth event. So overall, it was a 30% relative risk reduction. Yes, like I said, you still can have an event on medication, but the longer you're on it, the fewer events as you go through. It takes time, and hopefully you avoid the first event. But if you happen to get another event, then you're less likely to get the next one and the next one, etc. So this is a clever way to look at it. And it was the first time that I ever saw this was with the Reduce It trial when they went through and took a look at not just first time to first event, but subsequent and total events. And so I think here we're, not to be US centric, but Many of you that are on here probably practice in the US. And so looking at Reduce It USA, it was, a global study. And so they just looked at the United States. And I think what this tells me is probably we don't eat a lot of fish, and we don't eat a diet that has high EPA or DHA. And so it's even more remarkable in a US population. So the hazard ratio now is about 31%, right, in terms of relative risk reduction. And the number needed to treat is not 21, but 15. So arguably, probably the population that you really want to focus on are individuals that live in the US, where we live. Okay, same thing with the key secondary endpoint. It's just as, statistically and clinically, I would say, significant, and number to treat was 22. So again, pre-specified hierarchical testing. Let me just say that. USA group here, same pattern all throughout, meeting each endpoint statistically significant. In this case, total mortality was met. So maybe we stop people from getting hit by buses. I don't know. But in any case, I think it's valuable to consider different populations are different in terms of their overall cultural, social norms in eating, etc. Again, this is the USA subgroup in terms of total event. And while it was 31% in the total global study, it's even higher at 36%. Okay. All right. This is important because I've just kind of started us out with talking about triglycerides and how important triglycerides are in terms of probability of cardiovascular disease. But honestly, it's a little bit more gray than that in terms of triglycerides. So I often tell people I use triglycerides to sneak a really good medication on to their medical regimen, because here it didn't matter if triglyceride was greater than 150 or less than 150 in terms of achieved. Meaning, did you actually achieve a triglyceride less than 150, or did they remain above? And look at this line. It just didn't matter. If you were on Icosapent Ethyl and you remained above 150 or achieved less than 150, you still had clinical benefit above and beyond the placebo group. And then key secondary endpoints, it mirrors the same. Okay, so it's probably something about icosapentaenoic acid rather than the triglyceride lowering in this case. Here, time to first event by tertiles. This is by baseline, by the way. Even if you happen to sneak into the study and you weren't at 200 plus on your triglyceride, you were 81 to less than 190, benefit. If you were 190 to 250, benefit. If you were 250 to, my goodness, 1400, benefit. So I'm not sure that it's the triglyceride lowering per se, but certainly it's a population that we can choose and pick to initiate an appropriate therapy and see benefit in. I think here helps us with Sally, because some of you were asking, but that LDL cholesterol is still 75. We should get her to less than 55. And I would say, yeah, no, this is kind of my practice as well. I can do many things. And I would probably have approached the LDL, but also the icosapent ethyl, because in this baseline, by baseline, if you had been less than 67 and you started the icosapent ethyl, benefit. What if you stayed 67 to 84? Benefit. What if you were above 84? Like, Sally kind of fell right here. Benefit. Okay. So I think it squares well with how the 2026 guidelines said, well, if you can get to less than 100 on LDL on statin and there are persistent triglycerides, fasting 150 or greater, yes, this is why that data makes sense. And it's aligned with the clinical data. So here's a 67-year-old male, non-smoker, abstains from alcohol, vegan diet, strength training 5 days per week. He's, trying to do the things. But he had an MI 6 months ago, and then bypass was probably part of that. Clopidogrel 75 milligrams, telmisartan 20, rosuvastatin 20, ezetimibe 10. And then blood pressure, great. We don't have to do much there. Heart rate 68, BMI 21. But then as we look at the labs, total cholesterol 136, yay, less than 55 for LDL cholesterol, triglycerides 166, HDL 58, and this lovely new Lp(a). Maybe, some may know about it, may not know about it, but certainly this is in the risk level of 50 or greater by mass, by milligrams per deciliter. And then A1C is 5%, fasting glucose 78, EGFR, please be looking at EGFR and UACR, greater than 90, LFTs look great. So what would you recommend to further decrease the risk of another event in this patient? Do we increase rosuvastatin? It's already 20, LDL is already 45. Do we add a PCSK9 inhibitor because it's Lp(a)? And sure, why not drop that LDL cholesterol less than, it would probably cut this in half down to 22. I certainly have a whole bunch of patients that are down less than 20 and closer to 10. Or do we add Icosapent Ethyl? Maybe reduce it, right? Would tell us. But add a fibrate or niaspan. And certainly I didn't bury the lead here. We've already looked at and seen the recommendations that fibrate nor niaspan should be used to reduce cardiovascular events, class 3, okay? All right, so what about acute coronary syndrome? Well, I'm going to just walk through this really quickly because honestly, you are here for learning about triglycerides in the 2026 update. I hope these two scenarios have given you a little bit of food for thought with regards to making sure that we're thinking of the triglycerides, but importantly, thinking about Icosapent Ethyl. So just this is another way to look at reduce it, because the secondary event population, 70% of the 8,000, of that group, there was about 500 about 400 in each in the placebo and the icosapent arm that were just after acute coronary syndrome, like 12 months or less, okay? And what we see is that this is a really risky time for all of these patients. Post ACS, they're very unstable in terms of plaque, inflamed, etc. And so adding Icosapent Ethyl, once you make it past that first year, look at how much that diverges at about 18 months, and it's significant, right? 0.002 and close to 40% relative risk reduction. First, second, third, all those things. But this is time to first event. So remarkable outcomes for these patients. Okay. And I'm just going to move through this because this is the secondary. And then I think it's important, though, here's the part that I haven't addressed yet across the Reduce It trial. These are all bleeding treatment emergent adverse events. And yes, there's a little bit more in Vascepa versus placebo because part of the mechanism of Icosapent Ethyl is within the cascade of thrombosis. And so it does increase, potentially bleeds. And yes, it's statistically significant, but the question is bleed, how bad? And here, serious adverse events, it starts to kind of compress a little bit because you still have bleeding events in placebo group versus in the Vascepa. And these are serious, yes, I admit that, but no longer statistically significant. Meanwhile, this group is living, right? 25 to 30 and up to 40% almost relative risk reduction in events. So you're sticking around and you might have a little bit of bleed. Other bleeding related adverse events here, it just no statistical difference across those. So it's important to recognize that icosapentaenoic acid is part of the cascade. Can it increase bleed? Yes. Is there statistical significance in all bleeds? Yes. Is it statistically significant and serious? No. And do placebo folks have bleeds? Yes. Yeah. Okay. So I think that's important to recognize. Here's AFib flutter. I think it's important to recognize that this has been seen across the board in all trials, EPA, DHA mixed, prescription grade, and then EPA alone. So there's something about the omega-3s that do lead to a slight increase in atrial fibrillation. How much? And is it massive? Well, in placebo, remember, these folks had acute cardiovascular events or ASCVD events they're already at risk for developing AFib. And in fact, 6.1% in the placebo group who were not protected otherwise, but still will get AFib, and then it bumps to 7.9%. So yes, statistically significant, but I would argue you're around and living to have a atrial fibrillation, which is manageable, okay? Am I being cavalier? I'm not. These are folks that are alive, total mortality, cardiovascular death, etc. We're doing the right things, but making sure that we understand there's bleeding and AFib that can occur with these. So here's the mechanisms. I've been on a few of these papers, not these ones referenced, but it reduces, or at the endothelial layer, there's stabilization and passivation of plaque, nitric oxide production, endothelial, vasodilation, et cetera. There's this anti-inflammatory effect that occurs. So plaque is less likely to rupture, even if it's already there. So you're increasing the cap on it and reducing inflammation. And there's that plaque stability. So it's kind of this, 1, 2, 3 punch in terms of how the mechanism to reduce events occurs. So here, why does EPA alone work versus EPA DHA? And this is part of what we think or hypothesize, is that when EPA gets incorporated into that phospholipid bilayer, it's not haphazard, it's very stable, and it helps to stabilize that endothelial layer and that membrane, whereas DHA kind of is this haphazard, it's curled, and it can, at least the paper that I wrote that led to my doctorate anyways, what we see is that DHA may blunt the benefit of EPA. Almost like, giving someone that needs estrogen, hey, have some testosterone too with it. It's hormones, but giving two things that kind of contradict and interact with one another probably is not beneficial. And in fact, that's what we've seen across 4 different prescription grade EPA DHA trials, is it's neutral, no benefit. Okay. So here, I'm proud to, be part of the Evaporate study. It was a sister mechanistic study of Reduce It. And again, what we set out to do is, will we change plaque characteristics in those individuals on EPA versus placebo? And this was the 9-month results that you'll see here, but the rationale and design of the Evaporate study, I didn't add the other paper title of the 9 months, but this, it's the same. We were looking at smaller population, 80, but same kind of age group, a little bit younger, 135 to 499. They were same LDL cholesterol and on statins. And the primary endpoint was looking at progression of the low attenuation plaque. That's the riskiest of the plaque that can rupture, et cetera. So 4 grams versus placebo. And then we followed them for 18 months with a 9-month interim, and then the final. So what we found is, yes, in placebo versus Icosapent Ethyl, low attenuation plaque did reduce, but it just didn't quite meet statistical significance. Now, let me clarify that 9 months is really soon to see a difference in plaque. We just saw a late breaker at the American College of Cardiology. Olezarsen, ApoC3, reduces triglycerides remarkably, 50 to 60% or more, no change in plaque. 12 months, and this is at 9 months. So there's something about the way that icosapentaenoic acid interacts with plaque. And so we were already seeing the start of a difference here. So at the 9 months, these are pre-specified time point. We didn't just say, well, let's just check at 9 months. We were looking at it. And so you can see that it was a non-statistical 21% reduction in plaque. Total plaque also reduced, total non-calcified. So really in the end, what we said is this short follow-up, we, not powered to see anything at 9 months, but boy, there's quite a trend and multiple things reduced. So here's the Evaporate trial, the final results. Again, privileged to be part of this as an investigator. And this is what we saw. Placebo progressed, and across the board for Icosapent Ethyl, everything else reduced, and it was statistically significant. Okay, so in conclusion, the ability to retard the progression and induce regression of atherosclerosis was seen in evaporate, and that added to why we think it reduces events. So I'm going to move forward through here and get to one of that was CKM, by the way. I'm happy to kind of review that at some point with folks. But yeah, so this is what I wanted to kind of talk about. And unfortunately, I wasn't able to grab the graph, but they went back through Reduce It and looked at extreme cardiovascular risk versus just very high risk. And I would just say that this is a type from the acute coronary syndrome trial where those folks are extreme risk. We know this from the 2025 acute coronary syndrome guidelines, where that's the first time we saw LDL cholesterol less than 55, like immediately. Don't wait for, 2 events or 1 event with multiple risk factors. So essentially the extreme CV risk you saw through the acute coronary syndrome post hoc analysis with Reduce It. Anyways, we are near 15 minutes out. All of this is really the same as I've talked about with bleeding and atrial fibrillation, recognizing that it occurs. Probably, I'll just point out here in this. Oh yeah, here's the bleeding. So increased risk. So when we talk about bleeding and the mechanism of icosapent ethyl, just recognize that placebo was already at 10%. These are folks that are already on antiplatelet therapy, DAPT. Sometimes they're on triple, sometimes they're on a separate anticoagulant already for other reasons. And then when you add icosapent ethyl, yes, there's a statistically significant difference, but 2% absolute here, okay? And then atrial fibrillation, the absolute difference is 1%. This is statistically significant and different, but I would argue you're alive to experience 1% increased absolute risk of having atrial fibrillation, which we manage. Okay, maybe I'll end on a case and then open it up, Laura, if there are any questions and folks that wanted to discuss some things. So a 58-year-old male, non-smoker, MI 1 year ago, followed by bypass, type 2 diabetes, hypertension. So we're just like stacking everything onto this patient. But this is not a rare patient. Clopidogrel 75 milligrams, rosuvastatin 20, metformin 2000 once daily, losartan 50, metoprolol succinate 100. And here the blood pressure is 118/74. Magically, everyone's blood pressure is great. John Giacono would be happy. Heart rate 68, but BMI is 26. Okay. Total cholesterol 175, LDL 84, triglycerides 274, HDL 46, A1C 8%, and an EGFR and LFT that's within normal limits. Lots to think about in this patient, but certainly I hope I've taught you that this is class 3 to think about fibrates in this group. GLP-1 receptor agonist, yes, please. Although he misses the SELECT trial, he hits all of the sustained step trials. We already know semaglutide. We already know tirzepatide, dulaglutide, liraglutide, all have cardiovascular benefits. And honestly, when you add them into this space, triglycerides and HDL also respond when you manage this 8% A1C. Icosapent ethyl would not stop me from starting this. Different mechanisms, we've already seen it reduces plaque regression, plaque progression, and that plaque changes. So less of that low attenuation plaque. Lavazza, please don't. This is EPA DHA and neutral trials all throughout. SGLT inhibitor, well, that's arguable, but you would use it for the diabetes side of things. Don't know what his EF looks like. And then niacin, no. So no to niacin and fibrate. So I'll just stop there. And then Laura, I have a couple other slides, but we can go ahead and move to a Q&A.
Yeah, what a fantastic presentation. I learned so much, and we have some great questions that I'm excited to review with everybody. I would just add, as clinicians, we are always hesitant to talk about adding more pills. And for icosapent ethyl, when it's 4 more capsules, I think there's some provider bias about someone might not even consider that.
Yeah.
However, when you sell it as something that is more natural, perhaps that's, a fish oil. I have found that patients are much more willing than I maybe thought, just my own bias for it. So I think on top of all the fantastic data you showed, just keep in mind our own biases and bring that to your decision making. So thank you again for such a great presentation. I'm going to tell you we have two really good questions. I'm excited to hear your answers that I'll start with. And the first is, should you stop icosapent ethyl prior to surgical procedures due to the bleeding risk? What is your practice, Viet?
Yeah, this is a great question, and we just have not seen this as an issue. Again, these patients are already on antiplatelets, anticoagulants, and there are other things to stop that have guidance, for prior to surgery. But icosapent ethyl really isn't one of those. It just doesn't have a main mechanism of antiplatelet, anticoagulant action. And so, no, I would go ahead and proceed. Again, the majority of the patients did not see increased bleeding, and it's just not the mechanism that we think is driving benefit for these patients on the one hand. So, of course, you would stop an antiplatelet, anticoagulant, but in this case, it's just an observed increase in bleeding. Yeah, great question, by the way.
Great. And I have some surgeons at my institution who I find out after the fact have stopped
They
like
stopped this.
over the counter fish
Yeah,
oil, but they maybe aren't aware of icosapent ethyl. Nobody has tried to stop that, and I haven't
yeah.
seen any bleeding complications. So, or
Isn't
maybe
that
they are on
interesting?
top of the guidelines, like
Yeah.
surgeons usually are. Um, we have another question here. Can you start, and actually, that, what do you think about starting icosapent ethyl in patients with persistent atrial fibrillation?
Yeah, I mean, why not? So, I think nested in your question is, am I putting them at more risk for having recurrence of atrial fibrillation? And there is a slight increase. Remember, like the total absolute risk is 1%, but you're reducing their death by 20 to 25%. So I think you have to do the math with the patient, but they have to be comfortable with the AFib. Certainly, AFib is treatable, manageable. We already do the things, and a persistent AFib probably should talk to them about AFib ablation, and then certainly, left atrial appendage device if necessary. We just saw two great trials, by the way, at ACC that discussed this. It would not stop me from doing something that globally treats the patient, including reducing inflammation. But yeah, someone with persistent AFib, I don't know that that is something that would contraindicate, even on a relative basis, using icosapent ethyl. Yeah.
Yes. And I think, if it's persistent, maybe they're already in it. I'm
Yeah.
not worried about adding anything that might increase that risk. And for people who are paroxysmal, we have so many great points of technology now with smartwatches and smartphones that can really try to capture if someone is really worried about that, or the cardia device that can kind of monitor for that. But it's such a low risk that I think about it when I'm talking to a patient about the medication. But if they really have never had AFib, I really don't think it's something that I focus a lot of time on. I focus on the bigger risk reduction that you did such a great job reviewing yet.
Yeah, and thank you. I mean, let me just put this slide back up here for people to see, because it is important. I mean, yes, increased AFib, serious AFib flutter treatment, it was same, no statistical difference. Was there a slight increase in hospitalization? Maybe, no, not. Yeah, I mean, that's up here. That's nested in this first column. But in the end, I just, it's nominal, really. Statistically significant, but that's really a nominal increase for the benefit otherwise that a patient receives. Yeah.
I would add to Viet. I think there's so many more side effects to taking ibuprofen. Right?
Yeah,
Like we hardly spend
absolutely.
any time talking about these, but these are great questions, and these are the things that our patients are going to Google. So thank you for informing us, with kind of the data behind all of these questions. We did have one more question come in, and we might even have time for another if you have any burning questions for Viet. The next question is, can you or would you add colchicine to icosapent ethyl if appropriate? So a little
Oh,
side path, but I know
yeah.
I know you've got some knowledge in this space.
Yes. No, I like this question. So really two different disease states. Because you're talking about inflammation. I did say that, IPE is an anti-inflammatory. Certainly, absent elevated triglycerides, when would I use colchicine? And I think again, if all of the things are optimized and they're still having multiple events, then colchicine is something that you would add on. I kind of think of colchicine as like later, after everything else is done, especially with the most contemporary recent colchicine trial, which was disappointing to all of us. That, what was wrong with Lodoco 2, Colcott, it did not pan out. So in this case, would I add it? Yeah, after IPE is already done and I'm there, it's pretty solid data for IPE in elevated triglycerides. And then if afterwards there were still multiple events, then I would still kind of keep colchicine in the toolbox to use. So they're not contraindicated, but definitely kind of a different thought process. That's intriguing. What are your thoughts, Laura?
This is where the guidelines have started to recommend, following the HSCRP first
Hmm.
as kind of a risk enhancing factor, and now as kind of a helpful decision maker. So we know that there's lower inflammation with many of the therapies you've touched on today, but I think the data is very strong for statins. We know
Yeah.
we can lower HSCRP with other lipid lowering therapies, with lowering triglycerides, with lifestyle changes. So I think there's space for more research on this, but I would start with the more standard therapy and lifestyle changes to really try to lower that inflammatory state.
Yeah, yeah. I think you know, when I learned the first dose colchicine, it was dose to poop. So it's one of those that fortunately here it's not BID, it's once a day. But still, I just think pill burden on the one hand, evidence on the other, and you hit it. Statins, ezetimibe, bempedoic acid, all of these reduce HSCRP. GLP-1s reduce it up to 40%. So a lot of different things going on well before I have colchicine in the back of my mind, but it's there. It's kind of there to reach for.
I think that was our last question, Viet. Thank you again for sharing your expertise. I love the cases. I love the questions. I loved everyone who logged on, who really is supporting our mission of providing up-to-date education. And I want to really send my appreciation to Amarin for this generous sponsorship for APAC and really investing in the education of advanced practice providers, realizing that many of us are the boots on the ground who are taking in the latest guidelines and really bringing them to practice and improving patient outcomes. So thank you to Amarin. Thank you to all of you. And our first question I forgot to answer out loud is, will we have availability to these amazing slides that Viet prepared? And the answer is yes. So in our webinar portal, there will be access to all the webinars we've done in the last year. And so you'll be able to click on that in the next day or two. They'll be available. So thank you. Feel free to email APAC if you have any other questions or want to get more involved. And we thank you for your time. And Viet, thank you so much for this wonderful presentation.
Thank you. Appreciate it, everyone.